Thank you. Good morning, everyone. It's a pleasure to be here. There's going to be a common theme running through all of these talks. We independently made our own talks up and had different questions that we were asked to answer. But you can see through all the talks, there's a common theme, and you'll see that common theme in mine. I was asked to answer the question, is marijuana effective for treating opioid use disorder? So this is a downstream, fully codified substance use disorder. And is marijuana effective in treating it? That's the question that I need to answer. But before I do that, let's talk about the chronic disease that is addiction. As you can see up there, addiction is a chronic disease, just like diabetes, hypertension, and asthma. It's a chronic disease that's relapsing and remitting, just like those other chronic diseases. And just like those other chronic diseases, we employ medication treatment, we employ behavioral modifications and psychosocial therapy to help people achieve remission. And what's at stake here is a lot. Last year, according to the CDC, 72,000 people died of overdose. 2/3 of those people died of an overdose related to opioids. And you can see the phases that we have moved through in this disease, or in this epidemic, I should say. Initially, it was a prescription opioid epidemic. And right now, this year, we're at a 10-year low of opioid prescribing. We still have a long way to go, but we're doing better in that regard. What happened is that we exposed a generation to heroin. Once they were unable to get their prescription opioids, they went to heroin on the street, and it was a lot cheaper. And that was the second phase of this epidemic. We're currently in the third phase, which is the deadliest phase of all. And that phase is with synthetic opioids, very high potent opioids that one use could lead to death. One use when you relapse can lead to death. And that's what's at stake here. And you can see the statistics up here. Relapse to opioids is over 70% if they just receive detox. 91% of heroin users will relapse if they just receive detox. 60% of them will relapse within that first week. Why is that important? Well, only 11% of those that need treatment of an addiction actually get treatment. 11%. And of those 11%, only 50% get adequate treatment. So sadly, there's too many opioid use disorder patients that are getting detox only, and they're relapsing at alarming rates. And when they relapse, they're relapsing on very potent synthetic opioids that can kill them. So that's why the numbers keep going up. And it's a very powerful addiction. It has a stigma, a persona. There's associated risks of hepatitis C, HIV, and there's this delusional thinking about death. You would think that if a dealer has a spate of deaths in the product that they're selling, that people would stay away. But the truth is, if they have that spate of deaths, people flock to them, thinking that's the good stuff. I'll be all right. Those that died just didn't know what they were doing. I do. And it happens in counties all around Caron, where I work. So to understand how to prevent relapse, we have to understand a little bit about what's going on in the brain in the commission of active addiction. So what's happening in the limbic area of the brain is that there's a reward that's occurring, a reinforcement because of an increase in dopamine from their drug of choice. In this case, we're talking about opioids. And it's causing them to feel euphoric and a sense of pleasure. It's that area of the brain that we're targeting with our medications. That's reducing the cravings that they have, the triggers that they're experiencing, and they're able to kind of calm down and maybe sit down in treatment. And what's happening in the prefrontal cortex while someone is in active addiction is that it is not working efficiently. There's the ERISA model that Dr. Volkoff and Goldstein came up with that talks specifically about that. I won't get into all of that right now today. But what's happening is the prefrontal cortex is not functioning well when someone is in active addiction. But it's that area that we target when someone's in treatment. That's where biological methodology is second to psychotherapy, it's second to social therapy and social supports. That's where we're really targeting behavioral modification, support, 12-step supports. That area of the brain, prefrontal cortex, is a key area for us in treatment centers. So Why MAT? So the three types of MAT are methadone maintenance, buprenorphine maintenance, and naltrexone extended release or Vivitrol. They're the three MATs. MMT, which is methadone maintenance, was approved in 1972, buprenorphine maintenance in 2002, and extended release naltrexone in 2010. So what is medication-assisted treatment? It's counseling, behavioral therapies, and supportive services with medicine to alleviate, manage cravings, and reduce the risk of relapse. Much like other chronic diseases, we're using medications with other strategies to give someone the best chance of remission. And it's really a difficult task with opioids regarding relapse prevention because cravings are so intense with them and they last for so long, beyond other drugs, that we really have our work cut out for us. So it's really important that we get medication-assisted treatment started and begin the psychosocial therapies, behavioral modification, while they're in treatment. And this is a study showing just that. You can see in this study here from Baltimore, where I spent a good hour in traffic today, you can see that as they used more and more buprenorphine maintenance, more and more methadone maintenance, you saw a decrease in heroin overdoses. So that's a simple correlation. The next study is from Mass Health, and it's a very large study looking at buprenorphine maintenance, methadone maintenance, and just behavioral health therapies. And what you see in the green is no MAT, just behavioral health therapies, and you see that there's a lot of relapsing going on. In the other groups, buprenorphine and the methadone maintenance, there is a low degree of relapse. So this, to us as clinicians, says we need to use this medication and we need to make sure that it's inculcated in our treatment strategies. But as Dr. Clark said, that's not happening, unfortunately. MAT also manages post-acute withdrawal and even acute withdrawal. And this is just a timeline of both. You can see that acute withdrawal is over in about a week. It's a withdrawal that's not going to kill you, but you wish you were dead. That's what patients tell us, at least. And post-acute withdrawal can go on for quite a long time, weeks, maybe even months and years. And MAT can help with that. You can get someone on buprenorphine maintenance or methadone maintenance and really alleviate their post-acute withdrawal. And all this is very important because we have certain targets that are very important that science has told us we need to shoot for. So it takes about a year for relapse to be less likely than recovery. And it takes 5 years for someone to have the same prevalence of addiction as the general population. So this is a treatable disease. So someone who has an opioid use disorder, if we can get them to 5 years, their prognosis is excellent. So who supports MAT? Everybody. Who's using MAT? Not enough people. So this map shows what Dr. Clark was mentioning, which is the fact that most states are not utilizing MAT the way they should. The green is not for marijuana, I just want to be clear. The green is for low utilization, red is for high utilization. And you can see there's only a few states that are actually using MAT the way it should be used, which is high utilization. So let's talk about marijuana, specifically about the treatment of opioid use disorder. So Dr. Clark mentioned, she actually quoted the numbers, that in the National Survey of Drug Use and Health in 2017, that 4.1 million persons met the criteria for a marijuana use disorder, and only 2.1 met the criteria for an opioid use disorder. So this is an addictive substance, so we have to tread carefully over this. And marijuana is addictive, we know that at Caron, because 92% of our adolescents report marijuana as a drug of choice in treatment, 92%. And 13% of our opioid use disorder patients report marijuana as a drug of choice as well. So as been mentioned all along, it's really important to have evidence guidance. So on the left are the FDA-approved MAT strategies: methadone maintenance, buprenorphine maintenance, and extended release naltrexone. And what the FDA has given us is indications, uses, efficacy, safety, dosages, mode of action, method of administration, adverse reactions, drug interactions, and warnings. These are things that I sit down with my patients and talk to them about. Because it's real important that I get informed consent. I want the patient to help me pick their MAT strategy. And I gotta tell them why it works, how it works, and what are the possible side effects that they may experience. And they help me together pick the best MAT choice. On the other side, you can see that marijuana is not indicated as MAT for opioid use disorder. I can't have that talk with the patient. I can't get informed consent from the patient. And there's no consistency or standardization as a result. So FDA is very rigorous in how they do things. Clinical trials are well designed and monitored. There's too many questions when it comes to marijuana. Most of the evidence, as we heard already, it's anecdotal. There's some epidemiological studies that Dr. Humphreys talked about. But we've been here before. Again, Dr. Humphreys mentioned about heroin being the cure for the morphine epidemic post-Civil War. And the truth is, why take a risk? We have medicines that work that we're not using enough. Why choose a medicine that we don't know enough about? Thank you.